So, hello friends, let's continue our nutrition topic. So, the first part of the topic, which dealt with general aspects of nutrition, is over. So, the second part of nutrition, it involves various nutritional programs. And the third is nutritional disorders. So, again, the park would be our primary source of information. Uh, there is a table given. What are the various nutritional related programs that are being conducted? Some major programs we will discuss here. For example, vitamin A prophylaxis program is there, which is conducted by Ministry of Health and Family Welfare. We have an Anemia Mukbang, which was initially prophylaxis against nutritional anemia. We also have Iodine Deficiency Disorder Control Program. Ministry of Health is conducting it. Then we have a ICDS program, which is conducted by Ministry of Women and Child Development. We have Midday Meal Scheme, which is conducted by Ministry of Human Resource Development, which is now known as Ministry of Education. So let's start. The flagship program would be the Poshan Abhiyan. So Poshan Abhiyan. So this is a flagship program. We will be discussing the vision, goal, objective, and targets and the strategies of the program. First of all, vision of this Poshan Abhiyan is a Kuposhan Mukt Bharat. Kuposhan Mukt Bharat, which means malnutrition free India by 2022. This is the vision. The goal is to achieve improvement in nutritional status of children. So there are various groups of children between 0 to 6 years of age, adolescent girls, then pregnant and lactating women with fixed targets. Now, in order to achieve the goal, various objectives are set. And as we know, objectives are their broad areas, and targets are the specific indicators that are used. So let's see what are the objectives set out and what are the targets within the objective. So this table we can make. So we are clear that what is the vision, what is the goal. In fact, there is overarching objective is mission 25 by 2022. So what it means is that in National Family Health Survey, fourth, the stunting was found to be 38.4%. So the aim is to reduce this stunting to 25% by 2022. So how it would be done would be, first of all, what are the objectives? There are 5 objectives of the program. The first objective is prevent and reduce stunting in children. So children would be 0 to 6 years of age. What is the target? It is 2% per year, and in 3 years it will be 6% overall, because it is for 3 years. Second is prevent and reduce undernutrition and underweight prevalence in children. So again, 0 to 6 years. So that we are using stunting, one we are using undernutrition. So again, the target is 2% per annum, and for 3 years it will be 2 into 3, that is 6%. Third would be In case to reduce prevalence of anemia, to reduce prevalence of anemia among children. Children would be 6 months to 6 years. So 6 years would be up to 59 months. So this the target is here is 3% per annum. Stunting and underweight, the target is reduction by 2% per annum. 2% per annum, but anemia reduction would be 3% per annum, and for 3 years it would be 9%. The fourth target is to reduce prevalence of anemia again. It was in children, now it is for among girls and women in the reproductive age group, that is 15 to 49 years. Here again, the target is 3% per annum, and for 3 years it will be 9%. Finally, the fifth target is reduce low birth weight babies. So the target here is 2% per annum. So we can remember that stunting, undernutrition, low birth weight, all are 2% per annum. Anemia, two groups are there. One is children, one is girls and women in reproductive age group. There, the reduction target is 3% per annum. So this is the objective and the targets of the program. Now, overall objective we know it is Mission 25 by 2022. So that is the area. Now, what are the various strategies that are used? Strategies. So first strategy is convergence. What is convergence? That all the existing programs that are being done, which is related to nutrition, they would be not implemented in isolation, rather all of them would be combined. So for example, it will use ICDS. So ICDS scheme is there through Anganwadi work. Anganwadi services. Then there is Pradhan Mantri Matru Vandana Yojana. Then we have scheme for adolescent girls is also there. Then Janni Suraksha Yojana, then National Health Mission, then Swachh Bharat Abhiyan. All these programs will be converged in order to achieve the nutritional target. Second strategy is we will be following a life cycle approach in order to reduce malnutrition. So a life cycle approach would be that right from the womb, a lady is pregnant, then childbirth is there, then during childhood, then adolescent and the female reproductive age group. So intervention would be done along the whole life cycle. Third is already existing schemes are being converged and two additional schemes are being implemented. One is Sabla, Rajiv Gandhi, a scheme for empowerment of adolescent girls. So the Sabla scheme is it's for age group of 11 to 18 years adolescent girls. So the focus is to improve their nutritional and health status. Second scheme is Indira Gandhi Matritva Sahyog Yojana, which is now Matru Vandana Yojana, where conditional cash transfer would be done to those females, to pregnant and lactating mothers, in order to improve their nutritional health outcomes. So these are the three approaches that these strategies, this National Nutrition Mission, that is Poshan Abhiyan, is trying to use. So in order to understand it properly, so the major focus area would be ICDS scheme integrated within. So this would also be a part of Poshan Abhiyan. Along with that, there would be also Anemia Mukbang. So all the schemes are under this program right now. So first scheme that is of very much importance is Integrated Child Development Services scheme, and it is a very old scheme. Was formulated in 1975. So what is the beneficiaries? So beneficiary of this scheme are, first of all, is rural areas and urban slums, tribal and hilly areas, tribal regions. So all these urban slums are there. proper urban areas are not the beneficiaries of ICDS. You would not find Anganwadi centers in affluent urban societies. So what is the heart of ICDS scheme? Heart is Anganwadi center, and this Anganwadi center has to be established. And the criteria is for plains, it would be one Anganwadi center for 400 to 800 population. So in fact, the villages may have 3-4 Anganwadi centers because the population on villages is maybe 1,000 or 2,000, 5,000. Then, however, for hilly regions, the criteria is little less, 1 per 300 to 800. So the lower value is reduced rather than 400, 300. So this is the Anganwadi center criteria, population criteria. So what is the administration, how the administration is arranged for Anganwadi services? First of all, we have Anganwadi center. So Anganwadi center is manned by Anganwadi workers. Now, these 25 Anganwadi workers are headed by Mukhya Sevikas. And 5 of these Mukhya Sevikas would be headed by one child development project officer. So which would be at a community development block level. So at a block level, there would be child development project officer, which is the functional unit for this scheme. And it would be there for 100 villages. So that is there. Next comes what are the various services that are offered in ICDS. So we for services, we should know what are the beneficiaries and what are the services that will be given to these beneficiaries. First is the children from 0 to 6 years. Second is non-pregnant, non-lactating women in reproductive age. So that is 15 to 49 years of age females. Then third would be pregnant and lactating women. And fourth would be adolescent girls, that is 11 to 18 years of age. So what are the services that are given here? The services given are, so we should remember that this program is a combined effort of Ministry of Health and Family Welfare and Ministry of Women and Child Development. However, nodal ministry is the Ministry of Women and Child Development. What are the services that are given? Non-formal preschool education is given. Second is family planning services are given. Then health education is given. Then immunization facilities are given, health checkups are given, and referral services are there. And finally, so the Ministry of Women and Child Development have non-formal preschool education. Then we have free food supplementation that is done to the given to the beneficiaries. Now, how much food is given under free food supplementation? So for children that are normal, then there are malnourished children, and then there are pregnant and lactating women. So what are the calories and proteins that are to be given? So calories and proteins. So children, we give 500 kilocalorie per day. Malnourished children, we give 800 kilocalorie per day, but pregnant and lactating women 600 kilocalorie per day. Protein would be 12 to 15 gram per day for children, then 20 to 25 gram for malnourished children, and 18 to 20 gram for pregnant and lactating women. Overall, the target is that 1/3 of daily requirement of energy is given and 1/2 of the daily requirement of the protein is given. So remember, it is food supplementation and not whole of the food is given here. So these are the services that are provided by the ICDS, the Anganwadi centers. Right now, if we know what is the present status of this program, in 2019, there were 7,775 projects that were running. So we know one project is headed by a functional unit, one child development project officer is there, which is there for 100 villages. So 100 villages would be 100,000, 1 lakh population. So we have at present 7,075 projects running under this scheme. And there are around 13.7 lakh Anganwadi workers employed in this scheme. So with this ICDS scheme is over, let's move on to the next scheme. Next scheme is midday meal scheme. Midday meal scheme or midday meal program. So it is an initiative by Ministry of Human Resource Development, now called Ministry of Education. So what is the focus is that again we have to give free food supplementation to the children. The criteria is again it is supplementation. You remember it is not a complete food. So again 1/3 of the daily caloric intake and 1/2 of the daily protein intake is given. So what are the specific values that are given for primary school children and upper primary school? So calories are primary school 450, upper primary 700 kilocalorie per day. Proteins is 12 gram and that is 20 gram. And the cereals would be 100 gram here and 150 gram here. So again, the target is to provide 1/3 of the daily calorie intake at the school level and 1/2 of the protein intake at the school level. So with this scheme, let's move on to the next scheme, National Iodine Deficiency Disorder Control Program. It is a initiative of Ministry of Health and Family Welfare. So initially in 1962, we had National Goiter Control Program, which in 1992 was converted to NIDDCP, that is National Iodine Deficiency Disorder Control Program. This was on account of the fact that initially iodine deficiency was correlated only with goiter. But later on, it was realized that there is a whole spectrum of iodine deficiency disorders, which range from goiter, cretinism, mental retardation, then intrauterine fetal deaths. So all these iodine-related problems are tackled through it. So what are the various things that are done? First of all, we should know that what are the indicators used to assess iodine deficiency. First is urinary iodine excretion in pregnant. So 24-hour urine sample of a pregnant female is taken and we calculate the value of urinary iodine excretion in them. Second is neonatal. So in neonate period, neonatal hypothyroidism level is calculated by measuring TSH levels. Also, the goiter levels can be found out. So we should remember goiter is enlargement of the thyroid gland. Hypothyroidism is a this clinical functional entity. So iodine deficiency disorder would involve goiter, hypothyroidism, cretinism, mental retardation, and intrauterine death. So there are 6 diseases involved in it. So what are the steps that are taken under this program? Are first of all, we have salt iodization. So that is salt fortification. So according to the program, at production level, 30 ppm should be there, and at the consumer level at least 15 parts per million of iodized salt should be there. Now all the common salt has been replaced by iodized salt in India. So why there is a difference at production and consumption level? Because iodine is a volatile element, and during the process of distribution, it evaporates. So at the consumer level, it should be at least 15 parts per million. Second is that we are now planning to introduce something called twin fortified salt. So also called 2-in-1 salt. It would involve not only iodine plus iron also. So iron would be 40 microgram iron would be there, and the iodine would be there, and 1 milligram of iron would be there per gram of the salt. So this is there. In order to assess the effectiveness of the program, track elimination, what are the criteria to know whether the elimination has happened is, first of all, thyroid and the goiter in school children. If it is less than 5%, this means that it has been eliminated. Or urinary iodine excretion, say if it is less than 100 microgram per liter in less than 50% of the pregnant females, then is households with iodized salt. If they are more than if there is more than 90% coverage, then we will say that it is one of the criteria for tracking the elimination of the iodine deficiency disorders. Now let's move on to the next program, Anemia Mukt Bharat. Mukt Bharat. So what is the main aim of the program? Is to reduce prevalence. Prevalence means how many cases are there of anemia by 3% every year. So again, it is in line with National Nutrition Mission, 3% anemia reduction per year. So it would be in 3 years, it would be 9% reduction between 2018 to 22. Again, the target of 22 is the same here. So what is the strategy used in order to reduce anemia in India is 6 into 6 into 6. So what is this 6 into 6 into 6 is? There are 6 beneficiaries, there are 6 interventions, and there are 6 institutions through which the intervention would be done. So first of all, let's see what are the 6 beneficiaries of this program. First is we have children between 6 months to 59 months. Then would be children, older children, between 5 years to 9 years. Third are adolescents, that is from the age of 10 to 19 years, both male and female. Fourth would be women in reproductive age group. That would be from 15 to 49 years of age. Then fifth beneficiary is pregnant female. Sixth beneficiary is lactating female. So what are the interventions that are done? There are 6 interventions. We give prophylactic iron and folic acid supplementation. These tablets and syrups are given. Second is deworming. Deworming through albendazole would be done. Third intervention is a year-round behavioral change communication campaign with the tagline of Solid Body, Smart Mind, which is focusing on 4 key behaviors. What are the 4 key behaviors? Improving compliance with IFA and deworming. Then appropriate infant and child feeding practices. What are the appropriate practices of feeding a child, breastfeeding or these diets of the children? Third would be increase the intake of iron-rich diet. Iron-rich diet through diversifying the diet, quantity improvement, frequency improvement, or food fortification. And the fourth element is to delay cord clamp. So what and this would be behavioral change would be done in the healthcare professionals. Well, they would be encouraged to delay the cord clamping by at least 3 minutes so that blood from the mother goes to the fetus, preventing anemia. So delayed cord clamping would be encouraged. Fourth intervention we know is we will be testing anemia and treating. Test and treat policy would be there. We will testing the anemia with the digital methods and then treat the anemia. Fifth is that we will ensure that fortified food, iron fortified food is available in all government nutrition programs. Public health programs are there. And sixth would be there would be a focus on increasing awareness, screening and treatment of non-nutritional causes of anemia, like malaria, like hemoglobinopathy, fluorosis, or these interventions would be there. We should know specifically what are the doses of iron and folic acid supplementation and the albendazole dosage. So again, this is, so iron, how much iron is to be given, how much folic acid is to be given, and this is the beneficiaries. The first beneficiary we know like 6 months, children from 6 to 59 months of age, then children, older children 5 to 9 years of age, then adolescents we know 10 to 19 years of age, then women in the reproductive age group, that is 15 to 49 years of age, pregnant women and lactating women. So what is the iron level? The iron level would be in milligram and folic acid in microgram. Iron level for children would be 20 and folic acid 100 microgram, 20, 100, and it would be given bi-weekly. So bi-weekly means two times in a week. This would be given, and this would not be a tablet, rather a syrup would be given. That a 50 ml bottle would be there, which will have 20 milligram of iron and 100 microgram of folic acid. It has to be given 2 times in a week. So this was smaller children. With regard to larger, older children, 5 to 9 years of age, iron would be 49 milligram and folic acid would be 400 microgram. So it would be in the form of a tablet, which would be given weekly. Weekly means that once in a week. So once weekly, and the color of the tablet would be pink here. One pink tablet consisting of 45 milligram iron and 400 microgram of folic acid would be given weekly to older children. Now, adolescents. So now, for adolescents, reproductive age group, we know the age is 15 to 49, pregnant and lactating women. Dosage will remain the same. So dose would be 60 milligram of iron and 500 microgram of folic acid. So remember 20, 45, 60, 100, 400 and 500 microgram. So the 60 milligram of iron and 500 microgram of folic acid. So for adolescent females, as adolescent age group, we know it is a prophylaxis, we have to give weekly. Weekly, that is once in a week. The color of tablet will be blue. Now, women, all the women related tablets would be red in color. Like reproductive age group, pregnant and lactating females, they would be red. Adolescent would be blue, and the 5 to 9 years would be pink in color. Now, here the dose is same, but for pregnant and lactating women, daily one tablet of iron and folic acid with 60 milligram of iron and 500 microgram of folic acid. Red color tablet would be given. But for the women in reproductive age group, weekly red tablet. Because it is prophylaxis before anemia happening, we would be given this medication would be given. So weekly for the reproductive age group, and for pregnant and lactating women, daily red tablet consisting of 60 and 500. For adolescents, blue color would be used, and for older children, pink color, which has a lower dose. Pink color has a lower dose of 45 to 400 microgram. Now, what is the deworming strategy? So we use albendazole tablet. Albendazole is a 400 milligram tablet of albendazole is used. So again, we have this age group of small children, like 6 to 59 months, then 5 years to 9 years, then adolescents 10 to 19 years, then the reproductive age group 15 to 49 years, pregnant females and lactating females. So here we have to know how much is to be given. For children which are very small, we have to give half tablet. That is to be given biannually. Biannually means in 1 year, 2 tablets are to, another 2 doses are to be, half of tablet will be given. For older children, 1 tablet would be. Now for all other age group, we have to give one tablet, but the frequency will vary. For 5 to 9 years of age of children, older children, 1 tablet would be given biannually. So 2 tablets in a year. So in now, biannually means that in 2 years, 1 tablet would be given. 10 to 19 years biannually. This like once in 2 years. So in 2 years, 1 tablet of 400 milligram of albendazole would be given to 5 to 9 years, and then 10 to 19 years, 15 to 19 years. For pregnant and lactating females, only one tablet would be given. That would be given in second trimester. So it would be given once. And so afterwards, the pregnancy would be over, then biannually it would be started. This is the dosage regime for Anemia Bharat. And with this, I think a vitamin A prophylaxis program is left, which would be covered along with the nutritional disorders, because the treatment and prophylaxis is covered here. So now the third aspect of nutrition, we have already discussed general ideas of nutrition, nutrition programs. Now nutritional disorders. So these are very important. It is generally said alternatively one nutrition comes from nutritional programs and one comes from nutritional disorders. So again, let me share the screen for you. So nutritional disorders. So nutrition problems of in public health. First nutrition problem mentioned is low birth weight. So low birth weight, it is very high, 18.6% low birth weight is there. And the criteria is if the weight of a child newborn child is less than 2.5 kg at birth, it is a low birth case. Second is undernutrition. Undernutrition would have include this malnutrition. So it has various manifestations. First manifestation is wasting, then underweight, and then stunting. So these terms are important. So what is wasting? So wasting is when the weight for height, remember this thing, weight for height, there it is height here, and underweight is weight for age, and stunting is height for age. So the stunting is height. So height takes a time to reduce. So it shows chronic undernutrition. That is, if a child is underfed for a long period of time, then his height would be reduced. That is height for age. Underweight is weight for age. So it is a combination at a particular age group. If the weight is less, then it would be both combination of acute and chronic, both type of malnutrition, undernutrition. And the third is wasting. Wasting is weight for height. So it is if a height of a child is normal and the child the weight is less. This means acute nutritional problem is happened. So maybe some infections or something like that is there. What is the criteria for establishing? It is less than -2 standard deviation from the WHO child growth standards. So the WHO has some growth standards. If the child's weight for height or weight for age or height for age is less than 2 standard deviation from that WHO child growth standard, then we say a child is wasted, underweight, or unstunted. So this is there. Next is protein energy malnutrition. Protein energy malnutrition. So PEM is that initially what and there is severe acute malnutrition. Severe acute malnutrition is that acute malnutrition is there, and that is severe is there. So the criteria is less than -3 standard deviation of low weight for height. That is wasting. So severe. So acute is there. So we will use the wasting standard. Acute wasting, that is too severe, like -3 standard deviation. Or second, we can use is mid-arm circumference. So in children, the mid-arm circumference remains relatively same. The girth of the mid-arm remains same. So we can use it as a criteria. If we use a Shaki's tape, which is not expandable, that is like not stretchable is there, and the circumference is less than 11.5 centimeter. This means a child is suffering from acute wasting, and then person is labeled as severe acute malnutrition. What is the second thing is protein energy malnutrition. Protein energy, initially it was thought that there are two disorders, Kwashiorkor and marasmus. So The problem with kwashiorkor is mostly with inadequate protein intake. While in marasmus, protein and energy, both intakes are very low. So in marasmus, so like it's like very thin child is there. Thin child, baggy paint appearance is there, flaky paint like appearance of the hairs. Nutrition is not proper. While kwashiorkor, because proteins are less, and so in the blood, albumin level reduces. So if albumin reduces, the due to osmosis, the water would go into the skin. So there would be edema. The swelling would be there. Liver would be enlarged. Hepatomegaly. So these are two manifestations. Now, what is the WHO recommendation with regard to prevention of protein energy malnutrition in the community? So WHO expert group on nutrition in 8th group, it has said that we have to focus on four aspects. One is health promotion. Second is specific protection. Third is early diagnosis and treatment. And fourth is rehabilitation. So how it would be done? Health promotion. How will we promote? We will promote uh, healthy lactation. So education, distribution of supplements to lactating pregnant females, nutritional education would be there, home economics would be planned. So that would be health promotion. Specific protection would be immunization. We will give, uh, so if you give vaccines, then infections would be less. If infections would be there, malnutrition would be less. So that is a specific protection element. Food fortification would be done. Then child's diet would have protein and high energy rich foods like milk, eggs, fresh fruits would be given, should be given in specific protection. Third is early diagnosis and treatment. So the focus would be on surveillance, and identify through say growth charts. Growth charting would be done of the child. Anganwadi center, the growth charts are there. Then surveillance growth monitoring would be there. Then after identifying the cases, we will give treatment. Treatment would be in the form of food supplementation, say if an infection is there, that would be treated. Last is rehabilitation. So rehabilitative services would be provided, follow-up care would be provided. So this is the strategy that is given with regard to protein energy malnutrition. So the nutritional disorders of public health importance, we have already discussed. Low birth weight, what is the criteria? Less than 2.5 kg at birth. Then we have discussed malnutrition. So now third element is xerophthalmia. Xerophthalmia. So in India, xerophthalmia is of public health importance. What is xerophthalmia? It is a vitamin A deficiency disorder. So vitamin A is less in the food, resulting in some problems in the eyes, because a vitamin E is very helpful in the eyes. So what are the various types of xerophthalmia? First is primary, then is secondary. There are some WHO nomenclature. X means xerophthalmia 1, 2, 3. 1 is further divided into 1A, 1B, 3 into 3A, 3B. So let's start. What is 1A? 1A is conjunctival xerosis. The eye of the child would have uh, dryness of the conjunctiva would be there, and it will appear as a receding bangs after a sea-tide appearance. That kind of appearance is there. What is 1B? Bitote spot is there. So these are triangular spots that would be there on the eye. So this is a very specific indicator, a specific marker. Then 2 would be corneal xerosis, so dryness of the cornea. So initially there was dryness of conjunctiva, then bitote spot, then corneal dryness. Then 3A, 3B. 3A is corneal ulcer. Now ulcer has happened. And then keratomalacia would be that the cornea is melting. So these are irreversible changes. If like keratomalacia happens, then eye sight is permanently damaged. Now secondary xerophthalmia is of further three types: XN and XF, XS. So XN is night blindness. Night blindness is like nyctalopia. Now during night, person would not be able to see properly. Then F is fundal changes. Retina is problem happens. S means scarring in the retina would be there. So what is the first sign of xerophthalmia? Conjunctival xerosis is first sign. However, first symptom, that is a person would be telling what is happening, night blindness, but we cannot confirm it, night blindness. That is the problem with the childhood becoming in. So, but first, most specific manifestation would be white out spot, which is very easy to identify. So now, in order to know whether xerophthalmia is of public health importance, WHO has certain criteria. So what are the criteria set up for zero? So if prevalence of night blindness, XN, is more than 1% in the population, and presence of white out spot is more than 0.5% in a particular population, then we say that xerophthalmia is a public health problem. In India, it is there. In fact, it is close to, it is very high level. Let me check that figure. I think 4%, something like that, that is there. So what has the WHO recommended in this regard? What should we do? We should take three types of measures: short-term measures, then medium-term measures, and long-term measures. In the short term, what should we go for? We should go for large doses of vitamin A orally to the vulnerable group. Second, in medium term, we should focus on fortification of the food, and in the long term, we should ensure that in the long term, we should ensure that the appropriate dietary changes are happening, healthcare services are available to the population. In this regard, we have launched a vitamin A prophylaxis program. So first of all, what is the treatment? If we identify a person with the night blindness, so the treatment would be, we will give 3 doses on the 0 on the day he comes, next day, and the 14th day. So 3 doses of vitamin A would be given. We can give either oral dose or IV also can be given. So so we use if the age is less than 1 year and age is more than 1 year. If age is less than 1 year, we provide 1 lakh international unit. And if it is more than 1 year, we provide 2 lakh international units. So 1 lakh, 1 lakh, 1 lakh, 3 doses, there are 2 lakh, 2 lakh, 2 lakh. So this is the oral dose, and 1 lakh international unit is equal to 30 milligram. So that is the treatment of this. However, this injection, not IV, we give IM injection, intramuscular injection is here. The dose is 1/2 of the oral dose. Oral dose we know, like 1 lakh and 2 lakh, we will give 50,000 and 1 lakh international units of vitamin A. This is the treatment. So next, however, we have something called vitamin A prophylaxis program. So vitamin A prophylaxis program. So what do we do? In this, 3 things are being done. So first is that in pregnant and lactating women and the children, we are focusing on encouraging these groups, vulnerable groups, to consume vitamin A rich foods, which are basically these green leafy vegetables. Second is, we are providing for massive vitamin A prophylaxis. So along with immunization, measles dose, so we give a dose of vitamin A, massive doses of vitamin A. So first dose is 1 lakh international unit at the time of measles vaccination. So measles in 9 months. Afterwards, we keep on giving every 6 months. Every 6 months, we give to the children 2 lakh international unit of vitamin A till the age of 5 years. So the first dose is 1 lakh international unit, and then after every 6 months, 2 lakh international unit till the age of 5 years of the child we give. For 6 children, that is if diagnosis is there, so we know 0, 1, and 14 days, we provide these 1 lakh and 2 lakh doses of vitamin A. If we want to give IM, half of the doses would be given. So this was with regard to vitamin A, xerophthalmia. So some other nutritional disorders like vitamin B1, B2. So that is not important. That is biochemistry related. So we can fastly touch it because it is not of public health importance, because the prevalence is not that much. But iron is a public health. Anemia is a public health importance. So what is vitamin B1 deficiency? Vitamin B1 is thiamine. So what are the sources of vitamin B1? We would be beef, liver, nuts, rice, then gingerly seeds are there. What are the, it leads to what are the various diseases? Beriberi is there. It is especially for those populations which use polished rice. So rice has a outer layer which is rich in thiamine. So thiamine is vitamin B1. So when this is removed, the rice will appear shiny, but the nutritional value is reduced and very can happen. Then there is work, Wernicke Korsakoff of psychosis, especially in alcoholics. They need more vitamin B1, thiamine, but the dietary intake is not there because of the alcoholic. So Wernicke Korsakoff of psychosis happens. This is vitamin B1. B2 is the name of vitamin is riboflavin. So its deficiency results in ribinoflavinosis. So it includes cheilosis, stomatitis, angular glossitis. The glossitis is inflammation of the tongue. Tongue becomes the tongue is geographical tongue is there. Then cheilosis is the angle of the mouth. This angle of the mouth, there will be cracking. So these are the symptoms of vitamin B2 deficiency. B3, the vitamin name is niacin. The problem it causes is pellagra, and it was initially known by 3Ds. Now the 5Ds are there. What are these 3Ds? First, there is diarrhea. Diarrhea happens in niacin deficiency. Then dementia. Dementia means loss of memory, and then dermatitis. Dermatitis means inflammation of the skin, and there is a characteristic sign called Casal's necklace is formed. The hyperpigmented necklace around the neck is there. So that helps in diagnosis. However, there are two more Ds. One D is depression and one is death in the long term. So mostly in maize, those population which eat maize, this niacin deficiency is visible because maize has high content of leucine, which is an amino acid. Because of that, intake there is a relative deficiency of tryptophan, and tryptophan is needed for the formation of niacin in the body. So it is a precursor of a tryptophan deficiency in maize eaters, results in niacin deficiency called pellagra. Next is vitamin B5, name is pantothenic acid. Deficiency results in burning foot syndrome. Vitamin B6 is pyridoxine. It results in pyridoxine deficiencies happens in those patients who are taking isoniazid. Isoniazid drug, which is given in TB treatment. So there we should give pyridoxine along with it. So what is the deficiency manifestation of pyridoxine is microcytic hypochromic anemia and peripheral neuropathy is there. So next is vitamin B9, the folic acid. So especially in infants who take goat's milk, there are population where goat's milk is used instead of so infants, the primary source they give is goat milk, but the folic acid level in goat milk is very low. So because of this deficiency, there is a megaloblastic anemia. If a pregnant woman is having deficiency of folic acid, it results in neural tube defects are there. So the spine of the baby is not properly formed. So goat's milk is not that much beneficial. In fact, it lacks folic acid. So it's a food so we have to be careful regarding it. Then vitamin B12, it is called cyanocobalamin. So especially this vitamin is unique because this vitamin is not present in any of the vegetable food. So vitamin B12 would be only found in animal food. So in those strict vegetarians which do not take like animal food, B12 deficiency would be there. What would be there? Megaloblastic anemia would be there. Pernicious anemia would be there. Peripheral neuropathy would be there. Now it would be damaged. Then SCDSC, that is subacute combined degeneration of spinal cord. That is the manifestation here. Next is vitamin C. So we know vitamin C deficiency result. Vitamin C name is ascorbic acid. Its deficiency leads to something called scurvy. So scurvy is bleeding gums. So the rich sources lime, amla that are there. The scurvy manifestation are delayed wound healing, then fractures, gum bleeding. So these are the manifestations. Next is vitamin D. Vitamin D deficiency, we know, is called rickets and osteomalacia. So these are there, but these are not public health problems as such. So what are the various other public health problems? So anemia, we have discussed. Anemia Mukta Bharat is there. Nutritional anemia. So first of all, what is the definition of nutritional anemia? So it is a fourth public health nutritional disorder of public health manifestation. Let me pause for some time. So again, let's continue from where we left. So nutritional anemia, WHO definition is that if the hemoglobin value is less than the age groups recommended area, that is 11, 12, 12, 12. So that due to lower than norm, or which is a result of lower than normal take of one or more of essential nutrients. So it is also iron deficiency there, folic acid deficiency, all these megaloblastic. So that is a part of nutritional anemia. So so what are the interventions that are done? So first intervention is that iron and folic acid supplementation. We know we have Anemia Mukta Bharat, then we have iron fortification, and then some other strategies are also there. Now, next problem of public health importance. In nutrition programs, we have discussed Anemia Mukta Bharat, that would be there. At the same time, we can discuss some iron deficiency anemia related things, I think. Wait a second, because anemia is important. So iron. So let's do the iron nutrition completely. So what are the sources of iron? There are two forms of iron: heme iron and non-heme iron. The heme sources of heme iron are these animal sources, mostly liver, meat, poultry, fish. The non-heme iron this is their green leafy vegetables also there. So, uh, one more thing that we need to take into account is that there are certain foods which reduces bioavailability, and like phytates are there in then coffee, tea, all these are there, and there are certain more that increase bioavailability. In Indian diet, only one thing is there: ascorbic acid is there. So what are the iron deficiency manifestations? So they arise at various stages. The first stage is decreased storage iron. Then we have latent iron deficiency, and then overt iron deficiency. So what is the diagnosis? We know anemia diagnosis is based on HB value. So HB value is for males, for females. So females are further of two types: pregnant and non-pregnant. And then we also, these are so the criteria for males would be the highest, 13. Then for pregnant females, we have nutritional physiological dilution. We know that. So the criteria. So remember 13, 12, 11. That is the theorem. So for males, it is 13. For non-pregnant females, it is 12, less than 12. So if you're non-pregnant, so it's if a pregnant female, the dilution happens. So that criteria reduces. So it's like less than 11. So for children, we can divide it into less than 6 months and then 6 to 14 years. So for less than 6 months, we have 11, and for 16 we have 12. So remember this thing that 13, 12, 11. So for male it is 13. For non-pregnant females it is 12. However, for pregnant females, because the dilution, physiological dilution of hemoglobin happens, so it has to be 11. So this 13, 12, 11 criteria is there. So how would we quantify the anemia? It would be, first is hemoglobin value for diagnosis, and iron concentration, serum iron values can be there. 0.8 to 1.8 is the normal value, milligram per liter is there. Then serum ferritin. Remember, this is a very important one. Serum ferritin is the single most sensitive tool for evaluating iron status. So if it's less than 10 microgram per liter, then there is absence of stored iron. Then serum transferrin saturation. Saturation is there. So these are various investigations done. Treatment we know anemia Mukbang, what are the prophylactic system. So that is there. Now next problem of public health importance after nutritional anemia. The fifth problem is iodine deficiency disorders. So the intervention we have already discussed iodine deficiency, but we should know we were discussing. What is the percent? So India prevalence is there is something called Himalayan belt is there, which has high prevalence of Himalayan goiter belt is there. Iodine deficiency is there. So let me check what are the figures. So it is estimated that in India, 71 million people are having this problem. So control program, we have already done IGI, salt, iodine monitoring, manpower training, mass communication, that is also there. Next, I have a problem of nutritional disorder, public health importance is endemic fluorosis. So it is there in various, so what is fluorosis? When there is excessive fluoride consumption, result in fluorosis. Fluoride is a double-edged element. If it is less, it results in like dental caries, and if excess, fluorosis happens. So what is the manifestation of fluorosis? It manifests in dental fluorosis, skeletal fluorosis, and genu valgum. Dental fluorosis is when we take more than 1.5 parts per million per day, then skeleton 3 to 6 parts per million per day, then there is something called crippling fluorosis, more than 10. So what is the intervention done here? So we can change the water source, change the source of water, or we can defluoride the water. So how we can defluoride? There is something called Nalgonda technique. So it is Nalgonda technique is that it is developed by Niri Nagpur. First we will add lime, alum, and bleaching powder. Lab we can remember. So these three things would be added: lime, alum, and bleaching water. Second, we will do flocculation would be done. Third, sedimentation would be done. Fourth, filtration would be done, and the fluoride would be over. So that is there. And what are other nutritional problems? Seventh problem is letharism. So what is letharism? It is a paralyzing disease of humans and animals due to consumption of kesari dal. Kesari dal has something called DOAA, so which causes letharism. It is of two types: neuroletharism and osteoletharism. Neuroletharism disease manifestation is first is a latent stage is there, then no stick stage is there, then one stick stage is there, then crawling stage is the crawler stage is there. So neurological damage happens. It is used as an adult trend, and so it is there. Khesari dal, it makes you normal dal. It creates. What are the solutions for interventions? For the Kesari dal, let me add slides. So again, we are back. Share the. So we were discussing neuroletharism. So it is due to Kesari dal. It has BOA into it, BOAA. Now, what are the interventions in order to prevent this Kesari dal? We will give vitamin C prophylaxis should be there. Daily dose of 500 to 1000 milligram. Then we can ban this Kesari dal in the group. So it is used in as an adult trend. So it can be done in the states where it is gone: Madhya Pradesh, Bihar, Odisha, and Gujarat. Then third, we can remove the toxin. How can we remove toxin? Is first is steeping method. So we have to soak it in the hot water, and then water is removed. Because it is water soluble, the toxin will go. That is steeping. We can go for parboiling. In health education, genetic approach, and this is socioeconomic changes. All these things can be done. So this is nutritional disorders of public health importance is there. Next is there are certain nutritional this health related issues with which these nutritional factors are there. One is cardiovascular disease. In fact, the last year this question was asked in the UPSC mains examination, the optional syllabus. What are the nutritional factors in the cardiovascular disease? So again, we know that path is very important. They can ask anything. So first is what is the relationship of this diet and nutrition and CVD? Coronary heart disease, then blood cholesterol, and habitual diet have a triangular relationship. What is the cholesterol? Cholesterol is of animal origin, and increase in cholesterol, direct increase in coronary heart disease. Then lipoproteins. So lipoproteins, like there are various lipoprotein, LDH, VLDL, LDL, VLDL, and HDL. So HDL is protective, VLDL is very harmful. And fatty acids. So for saturated, the fatty acids are there, and there are polyunsaturated fatty acids. So it is said that polyunsaturated fatty acids are protective. And then triglycerides, then carbohydrates. Carbohydrates, more consumption is the population which consume more carbs are associated with less coronary artery disease. Then salt results in hypertension. Hypertension, in fact, is a risk factor for coronary heart disease. So that is there. So the diabetes is there given. Next is diabetes. For diabetes, the population is with regard to the quantity of the food. If a more quantity of the food, energy-rich food is there, then it results in diabetes. And there is second problem, that is recently research is being done. Some micronutrients, trace elements like chromium, like copper, zinc, may play a role in pathogenesis. And recently malnutrition associated diabetes is also happening. So that is like new development. So that is there. Now, third question they can ask is the cancer and diet. So first is 80% of the cancer are due to environmental factors. So what are the dietary factors? One is dietary fat. So it is related with colon cancer. Then dietary fiber. So more dietary fiber, less cancer. So dietary fat, more colon cancer. Third is micronutrients. Especially vitamin C deficiency is associated with stomach cancer. Fourth is food additives and contaminants. And this is the most important factor. There are various food adulterants and additives that are used, and they are responsible for, there is an association. So what are these? We can discuss. There is something called nitrosamines. They are responsible for some gastric cancers. Then there is some called saccharins. So that is the artificial sugar we know that saccharin, cyclamate. So they are weak bladder carcinogens. Urinary bladder carcinogens are there. And there is aflatoxin. So these are major food additives and contaminants which are responsible. So first two are food additives, nitrosamine, saccharin, and cyclamate, and aflatoxin is a contaminant. So which are related with this thing. This is a nutritional disorder. The last part we are coming now. There, what is this clinical assessment? How will we assess assessment of nutritional status? Nutritional surveillance, assessment of nutritional status. So how would it be done? It can be done through 7 methods. One is clinical examination. So in clinical examination, there are certain signs which have no association to nutrition, that some require further investigation, that some have proven value. For example, angular stomatitis is there, Pettit spots is there, the burning foot is there. So this clinical examination. Next is anthropometry. So anthropometry is we measure like height for it, weight for height, and growth charts are there. This can be done by non-trained health workers. Like that is one added advantage. Third thing is laboratory and biochemical investigations can be done. For example, serum ferritin can be used, serum iron levels can be there, level of various vitamins. So this can be used to malnutrition, the nutritional aspect. Then functional assessment. This is an emerging area. For example, RBC fragility. So this can be used to know the nutrition status. Fifth one is dietary intake measurement. If we take how much dietary intake is there, if it is less, then we can say its nutrition status is examined. Sixth is vital and health statistics. Health statistics, for example, mortality, morbidity, data causes mortality, nutrition related. So we can say that the problem is then. And the last one is ecological studies. We see the ecological factors, environmental factors that are related to nutrition. For example, food balance sheet, health and education services, socioeconomic status, these are things. Last but topic we have is something called nutritional surveillance. So here, one question that can be asked is what is the difference between growth monitoring and nutritional surveillance? So first is all we should know the basic idea, then we will know. So what is nutritional surveillance? So it is about keeping a watch over nutrition in order to make decisions. So surveillance word is watch with the decisions in order to make decisions. This a survey is done. So what are the difference? First is with regard to strategy. So the strategy here is to detect undernutrition. Detect. So we have to keep a watch, detect nutrition. Here, however, growth monitoring is a normal growth measurement is there. Like growth chart is there. So we have to maintain there. That is the strategy. What is the approach used? So here approach is diagnostic and interventional. Diagnose and intervene. Or the approach here is educational and motivation. So we motivate that if the growth is faltering, it's like from this level to this level, it is going. We will say no. So you should be eat more and all these things. Education is there. Approach is there. Third is enrollment. So here focus is on infants, all infants. Here a representative sample is taken and then a survey is conducted. Fourth is number. So this it is for small group. How because that is the point, and nutritional survey large group a representative sample is being taken. Fifth difference is that who will take and record the data. In growth monitoring, mother will do, while it trained worker is needed here. Then nutritional emphasis here is on maintaining good nutrition, while here emphasis on detect malnutrition. Response is home intervention with local language. Nutritional rehabilitation is done. Response time is very brief here, and it can take long time. Then in referral in for brief as brief possible to smaller center here. Nutritional rehabilitation centers are to be referred. So this table is also very important. How what is the difference between growth monitoring and nutritional surveillance? So with this, I think all of the nutrition comes to an end. Remember, there are three aspects to nutrition that, as mentioned in the what is the general aspect of nutrition, what are nutritional disorders, what are nutritional programs, and it is a very high yield topic. So thank you so much.